A 63-year-old white male has come in for his 6-month recare appointment and also complains that his tongue burns, especially while eating, and noticed several white patches in his mouth that won't go away. Patient is an uncontrolled diabetic with his last A1C at 8.2. Upon discussing recent history, patients discussed that he had recently taken amoxicillin due to a sinus infection. Upon clinical examination, it is evident that the patient has white patches that rub off on the dorsal surface of the tongue, the bilateral surfaces of the tongue, bilateral soft palate, and labial commissures. When these white patches are rubbed, it exposes erythematous tissue. His present illnesses symptoms began 2 weeks ago on the 8th day of his 10-day antibiotic course of amoxicillin for the sinus infection. His medical history of uncontrolled diabetes, type 2 diabetes with an A1C of 8.2. He is prescribed daily metformin, but he reports frequently forgetting to take it. He has a history of tobacco use, 1 to 2 cigarettes per day, moderate exercise 3 to 4 times a week because he goes golfing and doesn't use his golf cart. He has xerostomia due to smoking and diet soda consumption, 6 cans a day, uncontrolled diabetes, and the recent 10-day course of amoxicillin. His social history, he works as a motorcycle mechanic and has for the past 45 years. He enjoys golfing to de-stress and has a cigarette on the green. Main source of hydration is diet soda. He doesn't drink much water. Most of the men in his family over 50 have uncontrolled diabetes and limited mobility. He feels that his diabetes is well controlled due to his good mobility, regular exercise, and abstaining from sugary beverages by doing the Diet Coke instead of regular Coke. Clinical findings: the patient is alert and shows clear indication of pain, burning sensation, altered taste, soreness, and dry mouth. There is multiple presentations of white patches on his tongue, the labial commissures. They have diffuse borders and there are several white patches that vary in size from 1 millimeter by 1 millimeter to 6 millimeter by 6 millimeter. When rubbed, it appears erythematous and raw underneath the white plaques. He has mild angular cheilitis. No obvious lendopathy when lymph nodes are palpated. These are your pictures. Nice. Okay. So, question 1 for this case study: which diagnostic test would make the most sense? Throat swab culture, biopsy of lesion, rapid strep test, or blood test? Anyone? Do you want the pictures back up? Is it me? It is not me.
Strep test?
Nope.
A or B?
Are we swabbing his throat or taking his blood? The correct answer is A, because they look at it microscopically to see what kind of infection this is. Number 2, which of the following therapeutic treatments would you recommend to the patient? Broad spectrum antibiotic, nystatin oral suspension, NSAIDs, or corticosteroids? No. It's not D, everyone. Okay. B is correct. Nystatin oral suspension.
That's it.
Yeah.
Later, we'll tell you. Later.
Which of the following is not a risk factor for his condition? Smoking, recent antibiotic use, diabetes, or frequent sun exposure? D. Correct. Okay. What is the likely diagnosis? Lymphomas, leukoplakia, urethria migrans, or oral candidiasis?